Welcome to our video on infective endocarditis. Let's begin. Let's take a look at the topics we will be discussing in infective endocarditis. We will begin by discussing the various definitions used for this disease and then move on to discuss the pathophysiology. Next, we will continue with looking at the most high-yield risk factors that predispose patients to endocarditis and look at their clinical manifestations. We'll also discuss the steps to accurately diagnose the disease and management of the condition. Finally, we will look at complications that arise from the disease. Let's start with definition. Infective endocarditis refers to an infection of the endocardium of the heart, which usually affects one or more heart valves. It can be classified based on the type of valve that is involved, either native or prosthetic, the acuity of the infection, or based on the location of the infection. The disease classification is not definitive, but instead helps to guide management and therapy. The pathogenesis of infective endocarditis depends on whether the valve is damaged or not. When the existing valve is damaged due to any reason, it causes platelets and fibrin to adhere to that area. When there is a secondary infection, either from a distant site or transient bacteremia from mucosal injury, it can lead to secondary bacterial infection of the site. Further bacterial proliferation and immune activation leads to clot formation and valvular destruction, which leads to vegetations and loss of function of the valve. In some cases, infection with highly virulent organisms, such as Staphylococcus aureus, can lead to disease without pre-existing damage to the valves. This is possible because the bacteria are able to bind to the endothelial cell using extracellular binding proteins and then be internalized into them. Once internalized, they are able to avoid host immune responses and can proliferate uncontrollably, which leads to tissue destruction and loss of function of the normal heart valve. The bacterial vegetation, platelets and fibrin mixture on the valvular surface can embolize to various regions of the body, such as brain, kidneys, intestines, or lungs, and can cause infarction. The resulting valvular destruction caused by bacterial proliferation and the host immune response leads to regurgitation, affecting normal cardiac physiology. Before I go any further, I'd like to mention this image was contributed by Amboss. Thanks to our partnership with Amboss, I can highlight several important features of endocarditis. This image shows a cartoon depiction of bacterial colonization on the mitral valve. You can easily notice how this can impede normal valve closure and cause mitral regurgitation. This is a gross pathological section showing vegetations along the valve in bacterial endocarditis. You can see how these vegetations are large and can destroy valvular tissue and prevent proper closure of the valves, leading to regurgitation. Let's have a look at risk factors that can predispose someone to infective endocarditis. Patients who are male and greater than 60 years old are at risk for this disease. Pre-existing valvular disease, prosthetic heart valves, or a congenital defect in the valve or heart are risk factors that predispose to endocarditis. Previous episodes of endocarditis and poor dental hygiene are also possible risk factors. Dental procedures can lead to bacterial translocation through mucosal injuries and hence are a risk factor for endocarditis. IV drug and catheter use are also important risk factors as they can introduce pathogens directly into the bloodstream. Hemodialysis is a risk factor for the same reason. An immunocompromised status increases the risk for endocarditis by allowing bacterial proliferation without an appropriate immune response. The clinical manifestations of infective endocarditis are usually highly variable and may present as an acute, rapidly progressing infection or may manifest as a subacute or chronic disease with nonspecific symptoms. Most patients present with constitutional symptoms such as fever with chills, weight loss, anorexia, malaise, and arthalgias. A cardiac murmur is also a very common sign that is observed in a majority of patients. The murmur can either be new or a change in existing one. Patients may also present with signs and symptoms of heart failure such as dyspnea, orthopnea, and lower extremity edema. Heart failure arises in patients with endocarditis mainly due to valvular insufficiency that causes volume overload within the heart. Arrhythmias, such as heart block, can arise in patients who develop a perivalvular abscess. Infective endocarditis can cause many systemic manifestations due to septic embolization. Splinter hemorrhages of the nails are seen in patients due to microembolization and occlusion of capillaries. Janeway lesions are small, non-tender macules on the palms and soles that arise due to microabscess formation in response to septic embolization. Osler nodes are painful nodules on the pads of fingers and toes that arise due to a localized immune-mediated vasculitis due to septic embolization. Roth spots are exudative edematous, hemorrhagic round lesions on the retina with a pale center representing microinfarcts. While splinter hemorrhages, Janeway lesions, Osler nodes, and Roth spots are very specific for infective endocarditis, They are not commonly seen in all patients. When septic emboli travel to various organs, they can lead to organ damage from vessel occlusion and subsequent infarction. Renal artery occlusion can result in acute kidney injury causing hematuria. Additionally, patients may develop acute kidney injury due to circulating immune complexes and resulting glomerulonephritis. Splenomegaly and splenic abscesses with left upper quadrant pain may develop due to splenic artery occlusion with septic emboli. When right-sided heart valves are involved, there is a high risk for pulmonary embolization leading to symptoms of dyspnea and hemoptysis. Embolization to the brain can result in the development of stroke, hemorrhage, meningitis, or even an abscess. These lead to symptoms such as headaches, seizure, paresis, or altered mental status. This image shows splinter hemorrhages in the nails due to microvascular occlusion due to systemic embolization. This image shows an Osler node caused due to deposition of circulating immune complexes. Osler nodes, in contrast to Janeway lesions, will be painful and are typically on the pads of the fingers and toes. You can remember this because Osler starts with the letter O, and the patient may say ouch when you touch them due to pain. This is an image of Janeway lesions in a patient with staphylococcal endocarditis. You can see here that in contrast to the nodule on the finger seen in Osler nodes, Janeway lesions are flat, erythematous macules. Remember that Janeway lesions, in contrast to Osler nodes, are not painful. This is a fundoscopic image showing Roth spot in a patient with subacute endocarditis. You can appreciate that this lesion has a pale center with an edematous, hemorrhagic exterior and represents a microinfarct of the retina from a septic embolus. This table shows possible classification of endocarditis based on acuity, which includes acute and subacute endocarditis. The main difference between the two types of endocarditis has to do with the duration of presenting symptoms. Acute bacterial endocarditis has an acute onset of disease symptoms that develops within days to weeks. The symptoms of this type of endocarditis are usually more severe constitutional symptoms such as high-grade fever and severe anorexia. Subacute bacterial endocarditis, on the other hand, has a very insidious onset over a course of weeks to months with less severe constitutional symptoms, such as low-grade fever, back pain, and weight loss, and arthalgias. Acute endocarditis is caused by highly virulent organisms, most commonly Staph aureus, that affects healthy native valves. In contrast, subacute disease is caused by less virulent organisms, such as viridans, streptococci, and usually affects damaged native valves or valves with congenital defects. Another possible way to look at endocarditis is based on location of the valve that is involved. When the tricuspid or pulmonic valves are involved, it is termed right-sided endocarditis, whereas when the mitral or aortic valves are involved, it is termed left-sided endocarditis. The main difference between these two types of endocarditis has to do with clinical presentation due to embolic complications. Right-sided endocarditis presents with symptoms of dyspnea and possible hemoptysis due to pulmonary embolization and infarction. Septic embolization in the pulmonary vessels may also lead to abscess formation in the lungs, while volume overload in the right heart causes symptoms of right heart failure such as pitting edema and abdominal pain from hepatic congestion. Usually, right-sided endocarditis does not cause systemic complications unless there is a patent foramen ovale or atrial septal defect that allows the embolus to travel to the systemic circulation. Left-sided endocarditis presents with a wide range of symptoms due to organ damage from systemic embolization, which were discussed in the clinical features section of this lecture. Additionally, volume overload in the left heart can lead to symptoms of left heart failure such as dyspnea and orthopnea. Right-sided endocarditis is usually due to intravenous instrumentation or drug use that introduces bacteria, which eventually colonizes the right-sided valves. The main pathogens involved are usually Staphylococcus aureus and coagulase-negative staphylococci. Left-sided endocarditis commonly involves Staphylococcus aureus or viridans streptococci. The variability in clinical presentation and the importance of early diagnosis requires a high suspicion of the disease. Infective endocarditis should be suspected in patients with fever and appropriate risk factors, and should be on the differential in patients who have fever of unknown origin. The modified Duke criteria has been used to stratify patients into categories of definite, possible, or rejected cases based on clinical, pathological, and microbiological findings. The first step in evaluation of patients with suspected endocarditis is to take multiple sets of blood cultures and evaluation with echocardiography. Before the initiation of treatment, such as antibiotics, 3 sets of blood cultures must be obtained in addition to a transthoracic echocardiography. Additionally, an electrocardiogram, chest X-ray, complete blood count, and inflammatory markers are necessary to monitor the patient's condition. Echocardiography is an important part of the diagnosis in endocarditis and is required in all patients who are suspected to have the disease. Transthoracic echo is usually the test of choice. Transesophageal echo is used only when the patient has high risk factors such as prosthetic valve, previous history of endocarditis, heart failure, or presence of an intracardiac complication. Additionally, TEE can be used when TTE findings are inconclusive with high clinical suspicion. Findings in echocardiography that are indicative of endocarditis are presence of an intracardiac mass consistent with valvular vegetation, presence of a hypoechoic lesion indicative of an abscess, new valvular regurgitation, or dehiscence of a prosthetic valve. This is an image of an echocardiography that shows a valvular vegetation consistent with infective endocarditis. Remember that these vegetations can prevent normal function of the heart valve, leading to regurgitation, and also can lead to embolization as small pieces break off from the larger vegetation. Now that we've discussed diagnostic evaluation of endocarditis, let's take a closer look at the modified Duke criteria. The modified Duke criteria has 3 sets of criteria which include major, minor, and pathological. The diagnosis of definite endocarditis requires the presence of 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria. The diagnosis of possible endocarditis requires 1 major criteria and 1 minor, or 3 minor criteria. Please take a minute to pause the video so you can read through this chart. Let's take a look at a practice question to solidify this knowledge. A 37-year-old man comes to the physician due to fever and palpitations for the past 3 days. He is an intravenous heroin user. Vital signs are significant for a temperature of 40 degrees Celsius and a heart rate of 120. The physical exam reveals violaceous tender nodes on the finger pads. The echocardiography reveals vegetations on the tricuspid valve. Does this patient meet enough criteria for a definitive diagnosis of infective endocarditis? This question is about the patient with suspected infective endocarditis. The question asks if he meets enough criteria for definitive diagnosis of infective endocarditis. Let's recall that in order to definitively diagnose endocarditis, the patient should meet at least 2 major criteria, 1 major and 3 minor criteria, or 5 minor criteria. This patient is an intravenous heroin user, which is a predisposing condition and a minor criteria for endocarditis. Additionally, he has a fever more than 38 degrees Celsius, which is another minor criteria. The physical exam reveals violaceous tender nodes on the finger pads, findings consistent with Osler nodes. Osler nodes represent immunologic phenomena and are considered minor criteria. The echocardiographic evidence of vegetations is a major criteria, so this patient meets 1 major and 3 minor criteria that are enough for definitive diagnosis of infective endocarditis. The mainstay of therapy for endocarditis is targeted antibiotic therapy. The blood culture results guide the choice of antibiotics, and the antibiotics are typically given for a duration of 4 to 6 weeks, depending on further circumstances related to the case. Usually, empiric antibiotic therapy is not recommended unless the patient is acutely ill and has symptoms that are strongly suggestive of infective endocarditis. Even in these cases, blood cultures still need to be drawn prior to beginning antibiotics so that appropriate targeted therapy can be started as soon as possible. Empiric antibiotic therapy is usually dependent on several factors. For patients with native valves and with acute endocarditis, vancomycin and cefepime make up the empiric regimen. The same group of patients with subacute endocarditis are given vancomycin and ampicillin sulbactam. Patients who have a prosthetic valve less than or equal to a year after placement are given vancomycin, gentamicin, rifampin, and cefepime. If the prosthetic valve has been placed more than a year ago, empiric therapy includes vancomycin and ceftriaxone. Some patients cannot be managed with medical therapy alone and hence require surgical intervention. Surgery is indicated for patients with prosthetic valve endocarditis, valvular dysfunction, or perivalvular disease, heart failure, annular or aortic abscess, new-onset heart block, or fungal endocarditis. Antibiotic prophylaxis is generally not recommended for endocarditis, with a few exceptions. Patients undergoing invasive dental and respiratory procedures that involve mucosal incisions or infected mucosa require prophylaxis if there are any of the following features concurrently. These patient features include the presence of prosthetic valves, a prior history of endocarditis, unrepaired congenital heart disease, or repaired congenital heart disease with residual effects, or those who have undergone cardiac transplant with existing valvular regurgitation. There are many cardiac and extracardiac complications that can arise due to endocarditis. Cardiac complications in endocarditis include heart failure, perivalvular abscess, pericarditis, and an intracardiac fistula. Heart failure is the leading cause of death in patients with infective endocarditis and often occur secondary to valvular insufficiency. A perivalvular abscess can lead to conduction abnormalities in patients with infective endocarditis. It is important to know that a new onset heart block in a patient with endocarditis is indicative of a perivalvular abscess that involves the conduction system. Pericarditis in patients with infective endocarditis can lead to tamponade, and intracardiac fistulas can develop if the infection of the valves extends to the patient's myocardium. Additional systemic complications arise due to septic embolization. Complications in the brain can result in stroke, paralysis, encephalopathy, or even blindness. Additionally, patients can develop mycotic aneurysm if septic emboli allow an aneurysm to become infected. Emboli to the lungs can result in pulmonary infarction. Emboli to the spleen and kidneys are also common and can lead to infarction and abscess formation. Musculoskeletal complications of endocarditis include osteomyelitis and septic arthritis. Here is a CT scan of a patient who has infective endocarditis leading to septic pulmonary emboli. Notice the circular areas in both right and left lung that are indicated with an arrow. This is how septic pulmonary emboli appear on CT scan. A 37-year-old woman presents to the ED after having an episode of left-sided weakness. She states that this morning she woke up to numbness in her entire left arm and slurred speech. This episode lasts approximately 5 minutes and spontaneously resolved. She denies prior similar episodes. She admits to a history of recent heart attack 3 months ago. On physical exam, her temperature is 38.2 degrees Celsius, respiratory rate is 15, heart rate is 99, and blood pressure is 129/79. Her eye exam reveals white spots on her retina surrounded by hemorrhage. Her lungs are clear to auscultation bilaterally, and a new cardiac murmur is heard at the apex of the heart. She has tender red raised lesions on her toe pads. What is the most likely cause of her morning weakness? A. Subarachnoid hemorrhage. B. Epidural hematoma. C. Septic embolization. D. Atherosclerosis of middle cerebral artery. In this case, this patient likely suffered a transient ischemic attack, also known as a TIA, in the setting of acute bacterial endocarditis. This is shown by her new onset of left arm weakness and numbness associated with slurred speech that spontaneously resolved after 5 minutes. Her fever, Roth spots represented by her eye exam findings, new cardiac murmur, history of recent cardiac damage, ostler nodes on her toe pads, and stroke-like symptoms would fulfill the 5 minor findings of Duke's modified diagnostic criteria. In some instances, the vegetations developed in infective endocarditis can embolize and lead to ischemic strokes or transient ischemic attacks. Therefore, the correct answer is C, septic embolization. Let's discuss why other answer choices are incorrect. Answer choice A, subarachnoid hemorrhage, commonly presents in a patient as the worst headache of their life, or thunderclap headache, and will not resolve after only 5 minutes. Additionally, it would not lead to any of the other systemic symptoms the patient has. Answer choice B is incorrect because an epidural hematoma often occurs secondary to trauma, leading to damage to the middle meningeal artery, which this patient does not have. Additionally, symptoms related to an epidural hematoma would not be expected to resolve within 5 minutes or be associated with her other systemic symptoms. Finally, answer D, atherosclerosis of the middle cerebral artery, could lead to a TIA with symptoms like the patient is describing, but would not be expected to have the other systemic symptoms such as new cardiac murmur or fever. And that is all for this presentation.